A very good evening to all of you and a warm welcome to 4D, detailed discussion and dialogue for Indian diabetics. So today we have a very interesting topic and a very relevant, practically relevant topic for us. That is prevalence of diabetic nephropathy in India. And as you all know, diabetic kidney disease is the leading cause of chronic kidney disease in India, which is primarily driven by the rising prevalence of diabetes. And we have about 77 million patients with diabetes in India. And so our country faces a growing burden of diabetic kidney disease, which is going to significantly increase the morbidity and mortality. So, hence, to discuss about this very interesting topic, we have with us our speaker for today, Dr. Diabetes Specialty Center, Trivandrum. He's been a speaker at various discussion forums on topics including diabetes and elderly, diabetes and CKD progression, diabetes and technology, and also on newer therapies in diabetes mellitus management. He is an assisting national expert in certificate course in evidence-based management of diabetes mellitus. He has about 20 plus publications in reputed national and international journals on various topics, and he's also been part of many research projects, especially on diabetes. So, over to you, Dr. Akshay, and over to you for listening to this a very interesting topic of diabetic nephropathy in India.
Thank you. Thank you, ma'am. At the offset, let me thank the 4D and to begin with, let me thank Dr. Beatrice Anne for considering to take her time from her busy schedule to moderate this session. As she told very interestingly, we live in an interesting time where the management of diabetes goes through a lot of changes with respect to guidelines and day-to-day management of diabetes. And what not better to have a discussion on the prevalence of diabetic nephropathy, one of the most important complications arising out of diabetes. And I too eagerly look forward for presenting on this particular session when you're moderating. Thank you so much at the offset. And we all know that the prevalence of diabetes in India and the world is too huge. So if you're taking about anybody aged 20 or more than 20 years of age, the prevalence of diabetes is about 9.6%. So that is to say, around 90 million adults in the world are living with diabetes, and 1 in 2 adults with diabetes are undiagnosed, or contrary to that, 1 in 11 adults are living with diabetes. So the number of people with diabetes in India is second highest in the world, only next to China. And if the present trend continues, there is a very little contradictory opinion that we may be defeating the China people and maybe becoming the most coveted gold medal winner for having the most number of diabetic patients in the world, which is again very alarming. Now, diabetes, as we all know, is an iceberg phenomenon. It's an iceberg disease. All that we see clinically is just the tip of the iceberg. The most number of patients are submerged within the iceberg, themselves undergo undiagnosed. So that is the importance of this particular disease that we talk about in 4D. And I'm so happy once again to speak about the prevalence of diabetic nephropathy. And not to forget, furthermore, the kind of number of deaths that we have arising out of diabetes in a particular year is too huge, and diabetes itself solely becomes one of the most important factor for morbidity as well as mortality today. Going forward to the subject proper, the diabetes nephropathy or the diabetes kidney disease or the diabetic kidney disease. So it's nothing but the chronic loss of the kidney function due to diabetes. And we broadly stage it into two. One is the microalbuminuria and the other one is the macroalbuminuria. So microalbuminuria relates to the urine albumin excretion of more than 20 microgram per minute to less than or equal to 199 microgram per minute. And the macroalbuminuria correlates to a urine albumin excretion of more than or equal to 200 microgram per minute. What is so astounding here is that 1/3 of the diabetic patients showed presence of microalbuminuria after 15 years of the onset of diabetes, and less than half among them go on to develop a real nephropathy, which is very astounding. And diabetic kidney disease remains to be one of the single most important cause for ending up with the end stage renal disease. So when you compare with a healthy kidney that is there on the right side of your lower half of your screen, in the diabetic kidney disease, there would be a leakage of the proteins, which will in turn be able to be appreciated with the presence of the proteins in the urine. So when we come to the epidemiological prevalence of diabetic nephropathy in India, the International Diabetic Federation in 2021 quotes that the number of people affected by diabetic nephropathy has increased by 46% to approximately a whopping 783 million individuals. In India, the range of diabetic nephropathy ranges from 0.9% to 62.3% in various grades, and most of the studies done in India also second to that opinion. Now, in one of the studies conducted by Dr. Ranjit Unnikrishnan et al., titled The Prevalence and Risk Factors of Diabetic Nephropathy in an Urban South Indian Population, the Chennai Urban Rural Epidemiology Study, it was noted that the prevalence of overt nephropathy was 2.2% and the prevalence of microalbuminuria was 26.9%. The chances of developing a diabetic nephropathy was directly proportional to the duration of the diabetes that the particular individual had. It was directly proportional to the systolic blood pressure and also for other common risk factors for overt nephropathy as well. So the registry, much of the registries that are available in Indian context suggest that diabetes accounts for a little less than half of the total cases among the end-stage renal disease, and they in turn can end up having a renal replacement therapy as well. So now coming to the different stages of the diabetic kidney disease. So initially we have the glomerular hyperfiltration and the glomerular hypertrophy. So when somebody is on a glomerular hyperfiltration and a glomerular hypertrophy, there wouldn't be a presence of the microalbuminuria in the urine, and initially the glomerular filtration rate may be increased. This is partly due to the fact that when there is a glomerular hyperfiltration, the surface area of the filtration will be increased. Along with that, there can be an afferent glomerular arteriolar resistance which is decreased, and an efferent glomerular arteriolar resistance which will be increased, which will in turn lead to an increased renal blood flow and thus the increased glomerular filtration rate. From then, a particular diabetic can progress to a silent diabetic nephropathic stage where the glomerular hyperfiltration will slowly pave way for a glomerular basement membrane thickening and focal mesangial sclerosis, where again there will be a normoalbuminuria, and now the glomerular filtration rate can be normal. A little later, the diabetic may end up with an incipient diabetic nephropathy, where there will be a mild to moderate glomerular basement membrane thickening again with a variable mesangial sclerosis. But here we will be able to appreciate a moderate increase in the microalbuminuria level, somewhere between 30 to 300 milligram per gram of creatinine, and the glomerular filtration rate may be mildly decreased, or in few individuals it can still remain back to be normal. But by the time the patient progresses into an overt diabetic nephropathy, there will be a marked glomerular basement membrane thickening and a diffuse mesangial sclerosis with a severely increased albuminuria of more than 300 milligram per gram. And by the time the patient is in this particular stage, there will be a very much of a decrease in the glomerular filtration rate and also the presence of a hypertension. Last, the moment the diabetic ultimately ends up with an end-stage renal disease, there will be a very diffuse glomerulosclerosis with a very much of a decreasing albuminuria, and the glomerular filtration rate can be as low as less than 15 milliliters per minute per 1.73 meters square. That would be probably the stage where hemodialysis is indicated in the individual. So there are various pathophysiological mechanisms that works out in causing a particular diabetic nephropathy. It can be a cluster of multifactorial involvement with respect to a renal hemodynamic changes, activation of the renin-angiotensin-aldosterone system, ischemia and inflammation, and the oxidative stress. So when it comes to the renal hemodynamic changes, there will be a lot of mediated growth factors acting upon it, the IGF-1, the TGF-beta, the vascular endothelial growth factors, the prostaglandins, the glucagon, the endothelins-1, and the SGLT2. All these together corresponds to the efferent arterial constriction, which causes the glomerular hypertension and hence the glomerular hypertrophy and glomerular sclerosis. Similarly, a conjoined factor of an overactivation of the renin-angiotensin-aldosterone system due to the reactive oxygen species and the TGF-beta and the aldosterone induces podocyte injury leading to proteinuria, and also with the other advanced glycation and products and other mediators like the JAK and the vascular endothelial growth factors, which can also cause about the ischemia, inflammation, and the oxidative stress, together bringing about the tuberointerstitial fibrosis, the tubular atrophy, and even the mesangial cell expansion. So all these together put in one ends up causing what we talk about today as a diabetic kidney disease. So when we have such a dreaded complication in front of us, the most important question that we ask is how to go about controlling it. So the therapeutic strategy for a diabetic management in a diabetic nephropathy goes without saying is one of the important pillar in controlling the diabetic nephropathy. But not to forget, therapeutic management always needs to go in hand with a dietary restriction, also with a physical activity that that particular individual can suffers to. So among the endless list of oral hypoglycemic agents that we have, there are quite a few of those class of medications, oral hypoglycemic agents, which are preferred because of their nephroprotection. So the novel medication therapy would definitely be with the DPP-4 inhibitors in the form of gliptin. But here again, if there is a moderate renal impairment, I would rather suggest that we don't go ahead with the sitagliptin. And there are recent studies which shows that linagliptin is one of the safest drugs to give in case of a renal impairment as well as with a hepatic impairment. And to add to that, the SGLT2 inhibitors, the dapagliflozin, the empagliflozin. Coming to the fact here is one of an interesting piece of advice. The SGLT2 inhibitors, beyond a particular decrease in the level of the glomerular filtration rate, may actually bring the sugars down. But at the same point of time, the SGLT2 inhibitors are indeed a cornerstone in managing a diabetic nephropathy because they also help in renal remodeling. And the GLP-1 receptor agonists, which can regulate and restore the incretin effect. So the SGLT2 inhibitors, one of the novel anti-hyperglycemic agents, as we all know, they inhibit the renal glucose absorption and they help in natriuresis of the glucose. Along with that, there will be a little bit of a promotion of the weight loss, and there will be about a 4 to 6 millimeters of mercury decrease in the systolic blood pressure and about 2 to 3 millimeters of mercury decrease in the diastolic blood pressure, which helps in adding the SGLT2 inhibitors in a diabetic nephropathic patient, unless and until if it is severely contraindicated with respect to a severe urinary tract infections or a resistant UTI or an asymptomatic bacteria in case of especially postmenopausal women and other certain section of group of people. Whereas the DPP-4 inhibitors, they inhibit the GLP-1 and the gastrointestinal polypeptide. They stimulate the insulin secretion from the beta cell. So giving a combination of the SGLT2 inhibitors and the dipeptidyl peptidase 4 inhibitors would be a good fixed drug combination option in case of a diabetic nephropathy because they are safer, rapid, and we can still have a sustained glycemic control. And it also helps to improve both the insulin resistance as well as the beta cell function. And well, to a particular extent, it's overall cost effective as well. So to put it in a gist, the combination of an SGLT2 inhibitor and the DPP-4 inhibitors, they have different mechanism of action. With the SGLT2 inhibitor helping in the urinary glucose excretion, glomerular hyperfiltration would be reduced, sensitivity of the beta cells can be increased, and the sympathetic tone would be a little bit reduced, and at the same point of time, the DPP-4 inhibitors would help to reduce the oxidative stress and the inflammation, and also helps in decreasing the calcium deposition as well. So overall, the combination of an SGLT2 inhibitors along with the DPP4 inhibitors have multiple advantages from different mechanism acting, therein by reducing the hyperglycemia, reducing the serum uric acid levels, reducing the risk of causing a hypoglycemia, which is a very important consideration when you are treating a diabetic nephropathic patient. So this is the DAPSI study, a fixed drug combination therapy of dapagliflozin and sitagliptin given to about 358 patients were studied over a period of 3 months. So if you actually see here on the first graph in the left half of the slide, the blue line indicates the fasting plasma glucose and the other one indicates the postprandial glucose. So at the before the initiation of therapy, the fasting blood glucose was 178.8, which almost got reduced to 124 with the fixed dose combination of DAPA and SITA at the end of 3 months, and the postprandial glucose also decreased from 273 to 176. And most importantly, there was a considerable decrease with the HbA1c also from the baseline from 8.9 to 7.2 within a span of 3 months, which is again just wonderful. So the benefits of SGLT2 inhibitors in diabetic nephropathy, it has a very lower risk and it can almost, the estimated EGFR of by at least 50% reduction, it will be able to stop, thereby decreasing the progression to the end stage renal disease, and also helps an added benefits of decrease in body weight and blood pressure and decrease of hyperfiltration, all contributing in addition. Whereas with case of the DPP4 inhibitors, it helps in reducing the diabetic kidney injury by inhibiting the kidney index and attenuating the 24-hour urinary protein, and also reducing the blood urea nitrogen and the serum creatinine by increasing the extracellular matrix. So thus, the prevalence of diabetic nephropathy, especially in Indian population, is huge, and timely intervention with fixed dose combination of therapies along with diet management and physical activity, and most importantly, prevention is always better than cure. That is always the key. Over to you. Thank you.
Thank you, Dr. Akshay, for that excellent overview of the pathophysiology of diabetic nephropathy and also the therapeutic strategies available for management. So, to discuss further on this topic, let me ask you a few questions. What do you think are the primary risk factors for diabetic nephropathy in Indian diabetes patients?
Considering Indian diabetic patients, I think there are quite a few of the risk factors prevalent. One is an uncontrolled diabetes mellitus itself is a very important risk factor. Adding to that, an uncontrolled hypertension, dyslipidemia, and the a history of a personal history of smoking, and most importantly, another important risk factor that most of us forget, even in our clinical setting in the meager of time, is to ask whether there is a family history of a diabetic who has progressed to a diabetic nephropathy or a chronic kidney disease. I truly believe that is one of those most important risk factors, which even by the paucity of time, that one shouldn't forget to ask.
And with the rising prevalence of obesity, I think that also should be added as one of the risk factors for progression.
Very true. Very true.
So, can you tell us something about the latest guidelines? What are the latest diagnostic guidelines or tools for early detection of diabetic nephropathy in our clinical settings?
As per the latest guidelines, the classical investigational method has always been the 24-hour urinary microalbumin levels. But I think with the paucity of 24-hour admission being not a possibility with many of the patients, the latest guidelines recommends that of a spot early morning urine collection with a urine albumin creat ratio. So a urine albumin creat ratio would be one of the novel method to figure out that. Otherwise, the classical method of looking into the 24-hour urinary microalbumin, if it is less than 30 milligram per gram of creatinine, it's absolutely fine. 30 to 300 should be microalbuminuria, and anything more than 300 should be macroalbuminuria. But I prefer to have a urine albumin creat ratio checked at least once annually for all diabetic patients, whether he is suspected to go for diabetic nephropathy or not.
And creatinine value also would add some
creatinine value also would
screening
definitely
method.
add some value to it, and we will be able to estimate the glomerular filtration rate also, so that we will get to know whether how much percentage of the glomeruli which are non-functioning are still intact, and how much still helps in the filtration of the blood.
So we keep saying this patients with type 2 diabetes and diabetic kidney disease day in and day out. But what do you think are the main challenges which we clinicians face in managing diabetic nephropathy cases in India? And how do you think they can be tackled?
I would love to segregate this into three different things. One is resource, the second is the lack of awareness and education among the patients, and the third is logistics and technical allocation. So one important thing would be to educate the patient right on their first visit about the impending symptoms and signs of the complication and the need to have an early check at risk whenever they develop one such symptom. Secondly, to develop the resources for the same so that early detection can be made possible with early detection with simple, cheap investigations that we have today, and also to making such technical manpower as well as the logistics available for it.
Yes, well said. So, in India, we have so many over the counter medications that are available, and patients do take them. So, what do you think are any particular over the counter medications or supplements that diabetic patients should avoid due to potential kidney health risks?
And I'm so happy that I'm glad that you asked this question to me, ma'am. The one particular thing that I always do with my diabetic patients in their prescription is I always say no to NSAIDs. I've thought about having a seal, just like how we doctors have a seal for whether there is a drug allergy present, yes or no. Maybe we can always also have a seal putting a note to the NSAIDs over the counter prescriptions, especially with the multitude of ibuprofens and the naproxen that people get over the counter. I think that is one of the biggest things that we need to advise against to people with diabetic nephropathy.
I think that is an excellent idea that all of us can follow, and it will be beneficial for the patients as well. So, thank you, Dr. Akshay, for joining us today and for giving us a very good overview about diabetic kidney disease. And we've had a very interesting discussion. So, poor glycemic control, hypertension, delayed diagnosis, they all contribute to the progression of diabetic kidney disease and kidney damage. So, like Dr. Akshay had mentioned, early detection is very important, and using all the available therapeutic strategies is very important to manage and prevent the progression of diabetic kidney disease. So, thank you all once again for logging in, and thank you once again, Dr. Akshay, for joining us today.
Thank you so much.